Thank you again, Dr. Gatz, and also Dr. Takroni for your question. And now I would like to call upon Dr. Karim of Case Western Reserve University in USA to deliver her keynote talk entitled, "Can Early Atrial Fibrillation Ablation in the Setting of Sick Sinus Syndrome Decrease the Need for Pacemaker Implantation?" Dr. Karim?
Can you guys hear me?
Yes,
Okay,
yes, thank
excellent.
you.
All right, so I'm going to talk about my study at the end, but I sort of want to start out talking about the evolution of atrial fibrillation ablation trials. And at the end, we're going to talk about a couple of slides about sick sinus syndrome and if earlier ablation can be of benefit. I don't have any disclosures, objectives. So again, like I said, I'm going to start out with a few classic trials regarding rate versus rhythm control. Then I'm going to discuss the evolution for AFib ablation trials, just a very few slides for that. And then I'm going to talk about subgroups like patients with sick sinus syndrome that would benefit from AFib ablation. So everyone has heard of AFFIRM. These are the classic trials that occurred about 20 years ago. And when these trials occurred, our thinking about atrial fibrillation was very different, and the therapy for them was very different. So just briefly, AFFIRM had about 7,400 patients, mostly age of 65 and above, that were thought to have AFib that was recurrent or had some morbidity or mortality associated with AFib. And the patients were allowed to undergo more than 2 medications in each arm. One endpoint was mortality. The second was a composite endpoint of multiple things, and the follow-up was up to 5 years. So as far as the arms are concerned, this is where the problems of the trial started. So each arm had approximately 2,020 or 2,030 patients, but with rate control, the goal was a heart rate of less than 80 at rest and 110 with a 6-minute walk test. In this arm, they actually anticoagulated continuously with anticoagulants without interruption. And about 5% of the patients had AV nodal ablation, meaning they had to have a pacemaker implantation in this arm. And about 15% crossed over to the other group because of uncontrolled heart failure. The rhythm control arm, on the other hand, is where the bigger problems start. So about 2/3 of the patients were either on amiodarone or sotalol. And most of them had, if they had failed 2 antiarrhythmics and cardioversion on multiple occasions, then they went through either AV nodal ablation and a pacemaker or ablation, which again, very small percentage of the population, about 14 out of 2,000 patients went through AFib ablation. And the other problem with this trial was that as soon as the conversion occurred to sinus rhythm, if the patient remained in sinus, the anticoagulation was stopped, which led to some of the results. The bigger issue that I have with this is this arm, about 30% of the patients crossed over the rate control arm. So really, when you're looking at cumulative mortality, there was no difference in the groups. In fact, when it came to primary endpoints and some of the secondary endpoints, there was higher mortality in the rhythm control group. And it was a cumulative event. So when you look at Torsade, mostly occurring probably because of sotalol use, there was a little bit higher in the rhythm control group. The arrhythmic arrests that occurred were more frequent with the rhythm control group. And not surprisingly, a lot of this data is driven by stroke, and the events, strokes occurred more frequently in the rhythm control group because patients were not given anticoagulants once they returned to sinus rhythm. So of course they had more TIAs and strokes. Hemorrhagic bleeding that didn't involve CNS occurred more frequently in the rate control group. And again, this is the group that was continued on anticoagulation, so slightly increased bleeding is not surprising. And hospitalization was a bit more frequent in the rhythm control group. Unclear whether this is because of the antiarrhythmic or because of other reasons. The thing also I want to point out is look at the mortality in these groups. It's about 25, 26%, so very high mortality in both groups. The RACE trial came out around the same time in 2002. This is a smaller number of patients, but similar parameters of rate versus rhythm control. Usually they had to have AFib or flutter that was within a year of presentation. And if you were very advanced in heart failure, if you had used amiodarone or had a history of pacemaker, you're excluded. The primary endpoint was death from cardiovascular cause, heart failure, hospitalization, thromboembolic events, bleeding, and the follow-up occurred up to 36 months in this group. So in the rate control group, either you tolerate the symptoms and converted to sinus rhythm, or if you didn't tolerate symptoms, you were cardioverted. Look at this hodgepodge in the rhythm control group. So essentially, these patients kept undergoing cardioversion and different rhythm controlling medications. So they kept doing this over a long period of time. And out of the large group of patients that started out, 116 out of 522, so half of that. So out of 200 something patients, 116 remained in AFib, and this was just accepted in the group. So not very good rhythm control either. So again, in this arm, event-free survival was approximately the same. In fact, in the rhythm control group, the event-free survival was less, but not statistically significant. Then we skip quite a few years and we start talking about ablation trials, because this is not about rate and rhythm control anymore, but this is about the method of rhythm control. And yes, rate control is included in this, but this is where we start looking at subsets of populations that benefit from AFib ablation. So when you look at the Castle AF trial by Nasser Marouche, they looked at symptomatic paroxysmal persistent atrial fibrillation that did not tolerate antiarrhythmics or didn't want it. The inclusion was heart failure with EF less than 35 and a defibrillator. There was about 180 patients in each group, the catheter ablation group and the other group that was mostly consistent of rhythm control, about a little bit over 30% of the patients with rate control. The primary endpoint was composite of death and heart failure hospitalizations. So when you start looking at this data, interestingly, the median age was approximately the same. Most patients had persistent atrial fibrillation. The left atrial diameter was approximately the same in both groups. When you looked at how long-standing the atrial fibrillation was, it was approximately about the same. So about 30% of the patients had AFib for a long period of time, more than 1 year. Also, when you look at heart failure, most of the patients were within New York Heart Association 2 and 3, very few in 4 and very few in 1. All these patients had a low EF. Median EF was 32, 31, so nothing that's statistically significantly different. And most patients had an ICD. Actually, all patients had an ICD, with a small percentage of patients having a BIV. Then you look at the endpoints, and in these patients with heart failure, the patients who underwent ablation had lower mortality, death from any cause, lower heart failure hospitalization, lower cardiovascular death, and lower cardiovascular hospitalization. If you look at hospitalization from any cause, it wasn't any different, and the risk of stroke wasn't any different, because at this point we knew to anticoagulate everyone, so the stroke risk wasn't that high. When you look at mortality also, if you look at ablation versus medical therapy, there was a statistically significant difference. So here, when you're looking at follow-up for these patients with a median follow-up of 37.8 compared to rate and rhythm control trials, similar mortality. However, medical therapy had a worse mortality in these patients that had heart failure that either underwent rhythm control, rate control versus ablation. And this is the Kaplan-Meier curves for the same. So this is the probability of survival and heart failure hospitalization. So again, medical therapy did worse. Death from any cause, medical therapy did worse, even though for 36 months, they actually were about the same. But at 36 months, it started splitting. The probability of freedom from heart failure hospitalization, definitely medical therapy group had more hospitalization with heart failure. So definitely worse outcomes. When you did the subgroup analysis, almost every group did better with ablation, with few exceptions. So patients who were diabetic, they didn't necessarily do that much better with ablation. Patients who weren't on beta blocker did not do better with ablation. Patients who had a very low EF did not do very well with AFib ablation. So class 3 heart failure, borderline, somewhat benefited, but didn't benefit as much. Women tended to not do as well as men, but I will point out there was very few women in the trial compared to men. So I don't think we can hedge all our bets on this, but it is also historically known that women have more complications and they don't necessarily do as well with AFib ablations. Beyond Castle, so if you look at the meta-analysis that one of my fellows performed using 7 different trials for heart failure patients that underwent ablation versus rate and rhythm control, again, you're looking at sinus rhythm achievement favored ablation, heart failure improvement in EF favored ablation, Milwaukee heart failure, heart failure questionnaire. So patient had a perception that they did better with ablation. The 6-minute walk test is a bit all over the place. The trials that they tended to favor ablation, the trials that weren't so consistent had smaller number of patients. Again, if you're looking at all-cause mortality, with the exception of very small trials where there was very few people to prove this, the larger trials essentially showed that there was less mortality in this population. Again, in heart failure-related hospitalizations, the ablation arm was favored in the few trials that did look at it. Then we come to this year, where there was some groundbreaking trials that came out. The STOP AF trial came out of Cleveland Clinic with Dr. Wozni, and this is a multi-center cryoablation trial. Patients were between 18 to 80, and they had to have symptomatic paroxysmal atrial fibrillation. So you were given class 1 or class 3 antiarrhythmics or underwent an ablation. If they had a history of antiarrhythmic use, they had to be excluded. The follow-up was up to 12 months. The primary endpoint was freedom from initial procedure or recurrence of atrial fibrillation after 90 days. The 90 days being the golden period of time, which is considered the blanking period for AFib. At this point, out of the 203 patients, 104 underwent ablation, 99 went to antiarrhythmic therapy. The age was similar in the two populations. The time in paroxysmal AFib was about 1.3 years, and very few patients with congestive heart failure in this. When you look at the outcomes, not a lot of serious outcomes, but I mean, if you're considering that the percentage, I mean, yes, those 14% of the patients had serious outcomes overall. And what you're looking at here is you're looking at in the ablation arm versus drug therapy, they're very similar. MI, probably not related. AFib recurrence did occur in the AFib arm. Bradycardia occurred more frequently in the drug therapy arm. Chest pain equally in both arms. Oh, I don't know, it went back, hold on one second. Palpitations, pericardial effusion did occur 1 out of 104 patients. Ventricular arrhythmias, 1 patient out of 104. But if you look at symptoms with drug therapy, they were about the same, actually. They weren't that different. And in fact, they were more. So when you look at treatment success, which was defined as freedom from atrial fibrillation, no need for any procedures for atrial fibrillation or antiarrhythmic therapy or cardioversion outside of 90-day period, the drug therapy arm did not do very well. About 45% of the patients either needed more procedures or failed rhythm control or rate control, actually rhythm control. And in the ablation arm at 1 year, about 75% of patients had a successful maintenance of sinus rhythm. Then the early AF trial actually came out on the same exact day in New England Journal as well, but it's a Canadian trial by Jason Andrade, and it's 135 centers. What they looked at was, again, rate versus rhythm control in paroxysmal atrial fibrillation. The difference was in this trial, they put in a loop recorder to record every episode of atrial fibrillation that was over 30 seconds. And the trial was stopped early due to efficacy prior to full enrollment. So the composite endpoint of death from any cause, stroke, hospitalizations, or worsening heart failure. The secondary endpoint was the number of nights spent in the hospital. There was a safety endpoint as well, which was death, stroke, adverse events related to the therapy. And the secondary outcome was symptoms and heart failure. So again, very similar populations. I would point out our BMI is much higher in America than Canada, which is surprising, but not surprising so much because uh, probably that's true for most of the world. But otherwise, the arms were fairly equally matched. And the other thing I wanted to say was there was about 9% of patients that had heart failure in both arms. All right. So when you look at freedom from recurrence of atrial fibrillation with a loop recorder in, meaning if you even had a 30-second episode it counted, at 1 year with cryoablation in patients with paroxysmal atrial fibrillation, approximately 60% of the patients had no atrial fibrillation. And when you looked at the antiarrhythmic arm, about 30-something% of the patients did not have any recurrence. So essentially half of the other arm, as far as freedom from atrial fibrillation was concerned. Primary endpoints were met, which again, if you look at the hazard ratio, that's true, which is recurrence of symptomatic atrial fibrillation or atrial tachycardia. Even the secondary endpoints were met with the recurrence of atrial arrhythmias, and after 90 days, the recurrence of symptomatic AT after multiple ablation procedures, symptomatic atrial arrhythmias after multiple ablation procedures, after the 90-day. So all of these were the recurrence of atrial fibrillation essentially, and the percentage of atrial fibrillation. So the patients who were in the antiarrhythmic arm almost had double the burden of atrial fibrillation compared to the ablation arm, as I had shown in Kaplan-Meier. The quality of life, interestingly, there was not a lot of change in symptoms in both arms. This is about perception, I suppose, but as far as, recording, I mean, most of the patients had a loop recorder. So if they had any events, it would have been recorded. And this is just a graphic depiction of percentage of time in atrial fibrillation. Again, it was fairly small. And in the ablation arm, it was less than 1%. In the antiarrhythmic arm, it was approximately 2% for the percentage of patients that were in atrial fibrillation. Adverse events, about 3 to 4% adverse events that were looked at, and safety endpoints, it was 14 in each group, 14 in the ablation group, 24 in the antiarrhythmic group. You're looking at things like exacerbation of heart failure. Pericardial effusion, interestingly, occurred in the antiarrhythmic group, not in the ablation group here. Most of the arrhythmias and ACS occurred in the antiarrhythmic group. ACS is probably not related, but the bradycardia, the ventricular arrhythmias may be related to the antiarrhythmics that were used. Phrenic nerve palsy, pneumonia, hemoptysis occurred in ablation group. Hemoptysis also did occur in antiarrhythmic group. When you looked at adverse drug-related events, that's where you're going to see most of the problems with the antiarrhythmics that were used. And again, most of the rate versus rhythm control trials, the adverse events that were looked at were drug-related. So this is, again, going back to the rate and rhythm trial. Again, most of the antiarrhythmics we use do have side effects. This is something that a meta-analysis that we did with all the atrial arrhythmia trials regarding early atrial fibrillation ablation. And this is looking at recurrence of atrial fibrillation. All the trials favored ablation here. And as for recurrence of atrial arrhythmias, and for symptomatic arrhythmias, also the trials favored early atrial fibrillation ablation. So this is looking, so we looked at so far heart failure and how patients do with heart failure, with systolic heart failure. This is looking at all comers for AFib. And the last thing I want to end with, and I'm just going to present a couple of slides because our trial is ongoing, is looking at atrial fibrillation populations with sick sinus syndrome. So we're looking at patients who have sick sinus syndrome, which is a combination of atrial fibrillation usually, or any atrial arrhythmias. In this arm, we made it into atrial fibrillation. It could be atrial flutter as well, and have bradycardia or pauses. So within the population of patients that have AFib as well as bradyarrhythmias or pauses, we looked at this IBM Explorers database, which has about 6 million patients. Looking at the onset of AFib being the first event, we had, with the presence of sick sinus syndrome, we had 66,595 patients. We had divided the patients into 3 groups. Group 1 was AFib for less than 5 years of diagnosis that underwent ablation. Group 2 was patients who underwent ablation who had AFib for 5 to 10 years and then underwent ablation. And Group 3 was patients who had more than 10 years and underwent ablation. So the primary outcome that we looked at was with the need of pacemaker. And in this arm, when you look at it, the patients who underwent the permanent pacemaker are on this side, no pacemaker are on this side. Men tended to get less pacemakers than women. And the reason for that is essentially because women present later, they're ablated later, and there's actually quite a few trials about this. They're referred later for AFib ablation. Not surprisingly, if you're older, probably your sinus conduction is not as intact, and you undergo more pacemaker replacement than not. So then we come to the interesting part, which is looking at ablation within 5 years. So if you underwent ablation within 5 years, about 18% of the patients had pacemaker implantation, which is a lot less than historical literature suggests. If you had AFib ablation within 10 years, about 27% of the patient underwent pacemaker implantation. If it was after 10 years, then we're looking at about the same. So anyone who has sick sinus syndrome who underwent a AFib ablation within 5 years had a lesser chance of getting atrial fibrillation, getting a pacemaker implantation. The reason for this, there's multitude of reasons. Part of it is that remodeling that occurs in the left atrium. And even though there may not be reverse remodeling with ablation, which actually hasn't been shown, there's definitely a tempering of the progression of remodeling that occurs with atrial fibrillation once you're in sinus rhythm. Potentially left atrial size does not necessarily improve, but does not worsen. Scarring in the left atrium is less. It may also have some bearing on the fact that these patients have some ischemia as well that's underlying this. Having said that, what I haven't shown you is we had another graph that looked at patients with ischemic cardiomyopathy. We did adjust for that, and that did not play a role as well. So having said that, I just showed you the evolution of rhythm control strategies and tools over time. Patients with systolic heart failure benefit from atrial fibrillation ablation when they have AFib. And AFib ablation is probably a beneficial tool for rate and rhythm control earlier, especially in our sick sinus population. Having said that, I wanted to finish on time, so I thank you for your time and I welcome any questions.
Thank you, Dr. Karim. I couldn't get my mic on.